Okay, guys, so let's start nephrology week one. And week one, you guys are going over some anatomy and some basic stuff on your other courses. But what we're going to do is we're going to start week one with a review of imaging for the kidney. I'm going to give you examples of different types of examinations that we use for evaluating the kidneys, which are the vast majority of what you'll be using out there is what we're going to go over today. There's a few extra ones, but this gives you a very strong foundation. It's going to show you why to order exams, the benefits, the potential complications, and kind of describe each examination that is most commonly used to evaluate the kidney. So we're going to talk about KUBs. We're going to talk about ultrasound of the kidneys. We're going to talk about some CT scans. We're going to talk about IVPs and VCUGs, and those are our most common. We're also going to talk about some nuclear imaging of the kidney, which is not on there. The Lasix renogram, that's going to be toward the end of the lecture, but it's going to be a good lecture to give you a foundation of how we image the kidneys and some advantages of the different types of imaging. So let's start with just plain x-ray like we often do in our lectures. And kidneys are evaluated by plain x-ray most often by what we call a KUB. Now a KUB is just an x-ray of the abdomen. And KUB stands for kidney, urinary, and bladder, or abdominal x-ray. And the important thing on this examination is to know actually how the x-ray is performed. So a KUB is actually performed with a patient laying flat on the table or supine. That's important because KUBs are not only used to evaluate the kidneys, but they're also used to evaluate for the bowel gas pattern within the bowel. And we're going to go over that a little bit during when we talk about GI. When the person is laying flat on the table, it's hard to see abnormalities like free air and things like that, but we're going to discuss that in GI. The primary use for a KUB to evaluate the kidneys is to look for calcifications, potential renal calcifications, or calcifications within the ureters, or calcifications potentially within the bladder. Now, this is a nice example of a KUB, and what we're looking for primarily is we're looking for the renal shadows. You can see the renal shadow here on the right. It's partially obscured by bowel gas, ribs, and other soft tissue organs and things like that. But you can usually pick out some degree of renal shadow. Here's your renal shadow on the left. You can see that. And the right kidney is usually a little bit lower compared to the left one because you have the liver just above it. What you want to do is you want to look for calcifications overlying the kidneys. That potentially could be renal calcifications. Then you also want to look for calcifications along the tips of the transverse process, and you can see your iliopsoas muscle or iliopsoas shadow here. And then also on this side, that's the path of your normal ureter, is to kind of go right along the tips of the transverse process along the iliopsoas. It'll take a little bend where it goes over the pelvis, then it'll come back around and go into the base of the bladder. So if there's calcifications overlying the kidney or potential calcifications overlying the expected course of the ureter or within the bladder, we can evaluate that as a potential renal stone, which may be causing obstruction and altering renal function. Now, you can't see all the calcifications on KUB. There is limitations. It depends on what the stone is made up, or the composition of the stone, and it also depends on how big the stone is for us to be able to see it on KUB. But for an initial evaluation, it's a good study. It's also a good study in the fact that if you can see the stone, if you want more detailed evaluation, you'll go to a non-contrast CT. But a KUB, if you can see it, is a good way to follow that stone, to recheck and say a few days to see if the stone has progressed further down the ureter or if the stone has been passed. It's a good way to follow renal stones and not have to repeat CT scan, which is a significant more radiation compared to just a single view of the abdomen in a KUB. Here's an example of a KUB, and they have the outlines of the organs. So if you want to go back, you can kind of trace these outlines. You can see your liver, kidney shadows, spleen, iliopsoas muscle, like I just talked about a little bit. You can also see your bowel gas here with stomach, small intestine, a little bit of the large bowel and rectum here. And then we would look for calcifications overlying the kidneys, ureters, and bladder also. When we go through GI, we're also going to look for calcifications in the right upper quadrant, which would be consistent with gallstones or possibly calcifications of the gallbladder wall, like a porcelain gallbladder. We'd also look for calcifications down here in the right lower quadrant, which may represent a calcification within the appendix or a so-called appendolith, which would also be important to recognize. So just take a little while, go over these shadows, and then go back to the initial picture and try to pick them out and get used to looking at these structures on KUB. Okay, so the next imaging modality that we use very often when you evaluate the kidneys, especially if there's any type of acute renal failure or chronic renal insufficiency or elevated BUN and creatinine, is ultrasound. And ultrasound is a really good modality to evaluate the kidneys in the fact that there's no radiation, which is always good for everybody, but most importantly, ultrasound is really good because we don't have to give contrast to evaluate the kidneys, and that can be important if you have renal insufficiency to evaluate the kidneys. Now, this is a really nice normal ultrasound of the right kidney, and you can see your right kidney here, kind of a bean-shaped structure. You'll notice adjacent to the right kidney is actually the liver, and when we go through ultrasound, we'll go through this one view, which is really important. And when we try to evaluate the kidneys, one of the things we want to do is we want to put it up. We want to put the right kidney up against the liver. We want to put the left kidney up against the spleen to have a contrast and compare the echogenicity of the liver to the kidney. So going over a little bit of anatomy on your right kidney, this is the renal cortex and the parenchyma of the kidney. The darker or the blacker areas, that's actually the renal pyramids, and that's urine within the renal pyramids. That urine will collect there, and then it'll be transported into the renal pelvis for excretion. So those are your renal pyramids or calyces. And in the mid portion of the kidney here, you have your renal fat, which is in the medullary portion of the kidney. And you can notice that the parenchyma of the cortex and the echogenicity of the cortex of the kidney is similar to the echogenicity of the liver, and that's what we want. We want a similar echogenicity between the two for a normal parenchyma. If the parenchyma of the liver is increased or brighter, kind of like the fat within the kidney, that's what we see with fatty infiltration of the liver, and we'll go over that later in GI, and we'll go over it in ultrasound course starting this spring. If the echogenicity of the cortex of the kidney is increased, and not the medullary, but the actual parenchyma of the kidney, then sometimes that's suggestive of chronic renal insufficiency, particularly if the kidney is shrunken, it's small, and has increased echogenicity. That's suggestive of chronic renal disease. But this is an excellent modality to evaluate for the size of the kidney. We can get a very accurate measurement. We can compare it to the contralateral kidney to make sure they're similar size. We can also look at the parenchyma of the kidney, make sure there's no mass lesions. We can look for cortical scarring. We can look for increased or decreased echogenicity of the kidney. And one of the most important things that we can look for, especially with acute renal failure to rule out obstruction, is we can look for hydronephrosis. And we're going to go over that all in ultrasound. And we'll also go over that some as we go on through the renal evaluation here in the next 4 to 5 weeks. But this is a normal kidney. And a normal ultrasound. That's the benefits of doing an ultrasound. Primarily is ease of use, no radiation, no contrast. Really good for evaluation, a quick view of the kidney, especially when we're looking for hydronephrosis and potential obstruction. Some of the downsides to ultrasound, you can have some limitations or appearance and difficulty in seeing the kidneys, particularly if you have a large patient or there's a lot of bowel gas and things which can obscure the kidneys. So body habitus is a potential limitation given the positioning of the kidneys in their retroperitoneal location and potential to be obscured from body habitus and bowel gas. Also, with ultrasound, we can look at the vasculature of the kidneys. We can look at the renal artery. We can also look at the renal vein. And we're going to talk about that, especially when we talk about hypertension. Renal artery stenosis is one thing that can be evaluated with ultrasound and Doppler of the renal artery. It's limited in the fact that body habitus is a significant limitation to evaluating the renal artery. The renal artery can be a very small structure, and if there's a big person, it can be difficult to get a good picture of the renal artery. We can do certain profiles for renal artery stenosis, but one of the most important things, you really need to see how many renal artery ultrasounds they're doing at your location to see if the techs are really used to doing this type of examination, and also the radiologists are used to reading these exams, because these can be difficult exams to perform. They can be difficult to get an accurate measurement, and they can also be difficult if you're not doing them on a consistent basis. So it's very tech dependent. It's kind of like evaluating the appendix on a child, or a pyloric stenosis study. You really need to be doing quite a few of them to get used to them, and get really competent in doing these type of exams. So just kind of, if you're interested in a renal ultrasound and a renal artery study at your location, just ask, how many are you doing? Do you feel comfortable in doing it? Because it can be a difficult examination to get accurate results on. CT scan for the kidneys, in my opinion, is probably the most detailed and the most information that you can get on the kidneys. It's an excellent modality. It's extremely detailed in evaluating the size of the kidneys, the positioning of the kidneys, pathology of the kidney, including cystic lesions, solid lesions, masses, renal stones, hydronephrosis, congenital anomalies. I'm going to show you some examples of what we can do with CT. It's just an excellent modality to evaluate the kidneys. It's by far the test of choice to evaluate for renal stones and potential hydronephrosis, and the location of the stone, the size of the stone. So you'll know if you need to get somebody to go in there and take it out, if it's above 5 millimeters, or if it's 2 to 3 millimeters, the chances are that stone's going to pass on its own. So it's an exceptional tool to evaluate where the stone is and how big the stone is also. This is a really good modality to evaluate for renal cell cancer. It's also an excellent modality to evaluate for an infectious process such as renal abscess or perirenal abscess from pyelonephritis and things like that. In my opinion, it's a test of choice to evaluate the vasculature of the kidneys, so not only the renal arteries, for evaluation of renal artery stenosis, which I'll show you an example of a CT angiogram, but it's also really nice to evaluate the renal vein, particularly if we're looking for renal vein invasion from renal cell cancer and cancer of the kidneys. You can also look and evaluate for accessory renal arteries, which is a pretty common anomaly to have multiple renal arteries supplying the kidneys. That's important if the patient is going to have surgery, or there's going to be any type of surgery around the kidney to evaluate and let that surgeon know exactly how many renal arteries there are, if there's accessory renal arteries, and their location from the origin of the aorta and where they're coming from and where they're going within that kidney. It's really important. It's an excellent modality to evaluate that. The actual collecting system also is really nicely depicted with CT scan now, compared to what we used to have, which was primarily IVPs and VCUGs to look at the ureters. Now you can really, really see the ureters nicely on CT urograms, and I got an example of that too. So urograms are really nice to evaluate, particularly for cancers in the collecting system, such as transitional cell or potential filling defects like stones and things of that nature. One of the things with CT scan that we have to be aware of is when to use contrast and when not to use contrast. If you're really just worried about a renal stone and the potential side effect or complications such as hydronephrosis or thing like that, for a renal stone evaluation, contrast is not used to evaluate, because if you'll notice on this example, this is a CT with contrast. You can see that the contrast lights up the kidneys and is bright or white. That's also the same color as your renal stones, so that can obscure some renal stones. So when we look for renal stones, we don't use contrast, and that doesn't inhibit your ability to evaluate for hydronephrosis at all. So if you're looking at everything else, then we want to give contrast because it gives us so much more information. And remember, you can always do it with and without, and you have the best of both worlds on the abdomen. So this is a CT of the abdomen at the level of the kidneys with contrast. You can note contrast in the aorta, contrast enhancement of the kidneys, also your contrast of the liver, and then there's oral contrast as well as IV contrast. So CT is an excellent modality. Some of the bad things about CT, there is radiation, and it's a pretty good chunk of radiation, say, compared to a KUB. But the amount of information that you yield from a CT is so much more than a KUB. So you have to kind of weigh the risk and benefits of this imaging, but it is an excellent modality to evaluate the kidneys. Also with CT scan, of course, with giving contrast, you have to take into consideration renal insufficiency and things like that. This is an example of a CT angiogram, and you can see that it's just beautiful imaging. Here's the aorta. Here's your right renal artery, which is beautifully depicted all the way into the right kidney. Right kidney is a little bit lower than the left one because of the liver here. That's normal. And if you'll notice on your left side, you have 1, 2 renal arteries supplying the left kidney. So you have an accessory renal artery on the left. That's a really common occurrence. It's not that uncommon at all, but you can see there's no areas of stenosis within these renal arteries, either from arteriosclerotic vascular disease, which is most often what we see at the origin of the renal arteries in older individuals with renal artery stenosis, or there's no beating or kind of corkscrewing of the mid to distal portion of the renal artery, which is what we see with younger individuals with renal artery stenosis and subsequent fibromuscular dysplasia, or FMD. That's usually what we see with our younger individuals. But you can see how well the renal arteries are seen and depicted on a CT angiogram compared to the image of the renal ultrasound that I showed you before. So this is a 3D reconstruction over here, and you could take this and you could spin this and manipulate it, turn it, do whatever you wanted to do to it. It's really nice for a surgeon, especially if there was a renal lesion here somewhere. They were going to have to do a partial nephrectomy to know that there's multiple renal arteries supplying this kidney, the location of the renal arteries, and where they're coming off. These are coming off the aorta, but you can't have renal arteries which are actually coming off the iliacs and supplying the inferior poles. So it's a really, really nice study to evaluate for pathology and to preoperatively plan. Now, you can also do an MR angio of the renal arteries. That's completely possible, and it's a good study. I read a lot of those, or used to read a lot of them, and they're good for evaluating for renal artery stenosis. They're not hardly as detailed compared to a CTA, in my opinion, and it's usually a longer study to be able to, for the patient to lay there. The good thing with a lot of MR angio compared to CT angio is we don't have to give contrast a lot of the times with the MR angio. So if you have a person with severe renal insufficiency or potentially with bad allergic reactions to the CT dye, then MR angio is a good test of choice to go to. And you can always talk to your MR techs and see if they can do those 3D time of flights, which is how we evaluate for vasculature with MR. And they may not actually have to give contrast to evaluate the vasculature. So MR is also an option you can do for angiograms throughout the body. Here's an example of a CT urogram, and this is a really nice depiction. You can see your collecting system, the major, the minor calyces. You can see the renal pelvis here. The ureters are really nicely depicted all the way down, just going into the bladder. So really nice pictures of the collecting system. Before, all we had to evaluate this was primarily IVPs and VCUGs, which we're going to take a look at in just a minute. But you can see how well the collecting systems are actually seen now with CT urogram. Really, really nice depictions. You can move these around. You can change the intensity and see actually kind of dull this down and see inside the collecting system for potential filling defects and areas of obstruction. But this is a normal CT urogram. And we can also take later images and get the distal ureters really, really well. You can do delayed images when the bladder fills up with contrast and take a nice look at the bladder to look for wall thickening whether it's diffuse wall thickening, focal wall thickening, or potential filling defects within the bladder. Those are all possibilities for CT urogram. Now with CT urogram, we have to give contrast also. And without, normally we wait for the contrast to fill the vessels and enhance the organs. CT urograms are more of a delayed type study, so the contrast is actually went through the vessels, it's taken up by the kidneys, and then it's being excreted by the kidneys. So we image it on usually a delayed time compared to our other contrast examinations. But you can do a CT urogram with your other CT imaging and get a really nice complete evaluation of the urological system. Let's talk a little bit about a VCUG, and depending on what your practice is, you may or may not be familiar with VCUGs or use them or order them, but I want to go over them a little bit to show kind of what we see with them and how they're performed and primarily what they're used for. So VCUGs stands for vesicular cystourethograms, and the way those are performed is you actually have to insert a catheter into the bladder, and then contrast is inserted through the catheter in which it fills the bladder. And these are most often used in pediatric patients, especially small children with recurring UTIs. And one of the primary reasons that we use these examinations is to evaluate for reflux back into the ureters and up into the kidneys, which is a potential source for recurring infections. So the take-home message for these is that it's quite an invasive exam because a catheter does have to be placed within the bladder. There's contrast used on these exams, as you can see, but there's also radiation because when the contrast is inserted in the bladder, the child or the person is usually laying on the table, and we'll hit it with a little bit of fluoroscopy, which means it's kind of real-time radiation, and you can watch the bladder fill up. And once the bladder gets full, what we do is we look for reflux into the ureters, and then reflux of contrast into the kidneys. Now there shouldn't be any reflux into the ureters on a normal individual. So based on how much reflux, how far it goes, and whether these calyces are actually blunted, is the grading scale for what we get for ureteral reflux. And I'll show you that in just a minute. The other thing that we use it for is to evaluate the urethra. So once the bladder is filled and we've looked for reflux, we'll take out the catheter, and hopefully the individual can void, and we'll get imaging of the urethra. As you can see here, it's a really nice depiction. That's used especially to evaluate our male patients, our younger male patients, because we can look for posterior urethral valves, which is one of the most common causes for reflux and things like that in male patients. It's also good to use if you want to evaluate for potential trauma to urethra in an adult patient. And you can also use these type of examinations to evaluate for bladder trauma, whether it be an intraperitoneal or extraperitoneal bladder rupture. You can use VCUGs for that also, along with CT scan. And you can see this is a nice depiction of the urethra on a male patient. And you can see a little bit of reflux here into that distal ureter. So VCUGs are not often ordered, but they are something that we do on a fairly consistent basis to evaluate, especially for reflux into the ureters and to evaluate the bladder and urethra. I talked about that reflux. This is how we grade it. There's a grade 1 just into the ureter. Grade 2 goes into the kidney. And you can see these calyces start changing from sharp to kind of blunted. And then the tortuosity of the ureter begins to change, and that's how we grade it from a grade 1 to a grade 5 reflux. IVPs, or intravenous pyelograms. This is also somewhat of an older study. You can see that has a similar appearance to the CT urogram. IVPs were used a lot when I first started training in my residency, a lot by urologists, especially to evaluate the collecting system. And IVPs give you quite a bit of information. They really do if you take the time and you go through all the things that it can give you. Because what we're doing is we're actually taking multiple KUBs of the individual, and sometimes we'll do upright images, but they're usually multiple KUBs of the person after we give them contrast. So we'll do a pre-contrast KUB to look for calcifications, and then we'll give contrast, and we'll take pictures. So you'll do almost an immediate picture after you give contrast. Then you may do it 3 minutes later, 5 minutes later, 15 minutes later, 20 minutes later. And what we're doing is we're actually watching how the kidney takes up the contrast, concentrates the contrast, and excretes it into the collecting system. So if you have a kidney that's diseased or you have a kidney with a poor blood supply, then it won't take up the contrast as well or symmetrically compared to the contralateral kidney. So it's not only a study that can evaluate the collecting system, it's a study that can actually show you some degree of function of the kidney and give you an idea if one kidney is functioning similar to the other, and how they're taking up the contrast and excreting it. Primarily, it's been used for renal stones, to look for hydronephrosis, to look for renal stones. And some individuals actually say that these type of examinations will help push the stone on out because of the weight of the contrast. I've heard urologists say that before. Haven't really seen in the literature, but oftentimes, especially your older urologists will use IVPs to help maybe get that stone on out of the ureter and prevent somebody from having to go to surgery to be taken out. The nuclear evaluation of the kidneys is probably one of my favorites, and it's kind of an underutilized test. It's more subspecialist, especially your urologist and even nephrologist, and especially some of your oncological surgeons, especially for renal cell cancer and things like that, will use this exam. And often, like we've talked about before, we've talked about nuclear medicine a little bit, and we're going to talk about it quite a bit when we go into GI, because HIDA scans and gallbladder scans are something that you use quite a bit if you're dealing with GI situations. But this is a Lasix renogram, and it's a really, really good study. And as with most nuclear studies, this is more of a functional test of the kidney. So things that we've talked about before, like ultrasound and CT scan and MRI, and even the VCUGs and things like that, are more of an anatomical evaluation of the structure. So anatomical evaluation of the kidneys, whereas the nuclear study and even the IVP to some degree, like I talked about just then, helps us show how the kidney is actually working. It's a functional study of the kidney. So it's really, really good in that regard. So if you'll notice, what happens with nuclear studies is we inject a radioisotope or a nuclear element into the bloodstream, and depending on what it is, it's taken up by the structure or the organ that we're wanting to evaluate. So this nuclear isotope here is DTPA. We inject that, and you can see that it's intensely taken up by the kidneys. And then the patient just lays on the table, and we have a gamma camera, and the camera is actually taking pictures by the amount of radiation that's emitted. So it takes us or gives us images by how much radiation is being emitted. And from this emission, we generate images. So this is 0 to 3 minutes, 3 to 6, 6 to 9, all the way out to about 30 to 33 minutes. So what we're wanting to do on this examination in particular is we're wanting to evaluate the function of the kidney. So we want to see, we want to give this radioisotope. We want to see that it goes to the kidneys. It's taken up by the kidneys. It's concentrated by the kidneys, and then it's excreted by the kidneys. And we want to make sure that that's done symmetrically. So a lot of the times, one of the things that we do this for this type of study is we can evaluate the function of the right kidney compared to the left kidney, and that's important sometimes if they're going to take a kidney out, because you can put a region of interest and see how much is taken up by a kidney and how much is concentrated and excreted by the kidney compared to the other side or the other kidney. It's a really good way to do that. Most often what we'll do is we'll have an individual with a dilated collecting system, especially possibly a younger or middle-aged person, that's been read as hydronephrosis. So the collecting system's dilated, like you can see here in this left kidney. You can see the collecting system dilated compared to the right, and the ureter dilated. And they'll call this hydronephrosis, but we can't see anything obstructing it. So we don't know if it's actually obstructed, or we don't know if it's just dilated or ectatic. And this is a really nice study to evaluate for that, because you'll notice we'll give Lasix during this examination, and if there's an obstruction, this kidney won't wash out, or the Lasix, when we give it, should kind of, just like if you give Lasix on any individual, it'll kind of wash out the kidney and it'll increase excretion and get that urine out of there. And if there's a physical obstruction actually of the ureter, then it won't matter if you give Lasix or not. That kidney will not wash that urine or radioisotope out of there, because it's actually an obstruction in place. But if it's just a dilated ectatic collecting system, when we give the Lasix, then it'll wash out normally, because there's nothing obstructing or impeding the flow of the urine. And this is a really nice test to depict that. So if you'll notice, you can see that the collecting system's dilated here on the left compared to the right, because we don't really even see the right. But you'll give your Lasix, like right here, at 12 to 15 minutes, and then just kind of watch these kidneys, see how they kind of just fade away over time. To 30 to 33, they're pretty much gone. So they both completely washed out the radioisotope, and they've washed it out symmetrically. So that lets us know that this collecting system isn't obstructed, it's just ectatic or dilated. And if you'll notice your curves, these are intensity curves that the computer generates. You got the left kidney and the right kidney, and you can see that really nicely that the radioisotope is taken up by the kidneys symmetrically. It peaks, you give the Lasix, and then it both washes out symmetrically. So the function of both kidneys is extremely similar, and the excretion is extremely similar and normal. So this is a really, really good depiction of how the kidney works, is a Lasix renogram. It gives you a ton of information, and it really isn't utilized to the degree it should be used because of the information that it gives. Nuclear medicine is a great subspecialty, and it's really, really good to give you a lot of information that you can't get other places. Not only can we evaluate for the concentration and the function of the kidneys and the excretion of the kidneys, but we can also make sure that the radioisotope is being given equally. So you'll see both of these kidneys kind of light up at the same time on the initial exams. That's important, because if we have abnormalities such as an obstruction, then they'll be somewhat delayed on the obstructed kidney. Or if you have an abnormality like a renal artery stenosis, then the radioisotope will be delayed, and you'll have delayed enhancement or delayed intensity of the affected kidney also. So you can get a ton of information from this evaluation. You can see the size of the kidneys are similar. You can see the positioning of the kidneys are similar. All those are important tools, important information that you can get. And remember, our kidneys can not only be in different locations. You can have pelvic kidneys. You can have anywhere. If you want to go back to your embryology, your kidneys originate at the mesodermal ridges, kind of in the pelvis, and they migrate upward to their normal location. So anywhere along that migration track, these kidneys can potentially be, and that's why we'll have pelvic kidneys. You can have one kidney. You can have more than one kidney. So there's a lot of anatomical variations that we're going to look for too, and we can do that with ultrasound, CT, or even you can see if it's functioning. You can see it uptake here on your Lasix renogram. So it's important to evaluate the kidney for multiple different reasons, but your basics that we just talked about, your basic imaging and your foundation for imaging the kidney is going to be your KUBs, your ultrasounds, your CTs, your VCUGs, IVPs, and then your nuclear medicine Lasix renogram. That's kind of a very good foundation to have a different and a complete evaluation of the kidneys. And what you use to order kind of depends on the situation of what you're looking for, and then also the renal function. if you got to be careful with contrast if you've got renal function, and we're going to talk about that later about when to give contrast, when not to give contrast, and things like that. So that's kind of a little bit of a background of the different imaging modalities. We're going to build on that in the next 4 weeks, kind of look at the pathology and look at these modalities and how it helps us to evaluate the pathology of the kidney. So hope you enjoyed the lecture. Thanks, guys.